And I want to also introduce Apostolos in the sense that he's a partner in Preciseu. He's a researcher at Forth, which is an institution in Crete. He can tell more about that. And he's a very active partner in the project. And he just jumped, you can also share with us some of the thoughts that were also discussed in Cyprus, according to the, I know, so yes, taking the occasion of the EU presidency of the Union, there was specifically a high-level event on health data. So you were there. Thank you, Apostolos, for joining us as well.
Excellent. Thanks a lot, and thanks for the opportunity to present here also my perspective and what I have heard in Cyprus. Can you see my slides or the
Yes.
presenters mode?
Yes, with the notes? Thank you. Yes. Oh no, with the presenters, no, just the slide.
Just a slide. Excellent. So. My name is Apostolos Dimitriadis. I work as a business development innovation manager at the Institute of Computer Science at Forth. So I'm going to give, let's say, the perspective of coming from. No, I'm working at a unit at a research center which is selling software to hospitals, integrated care systems, which monitor all the administrative and non-administrative functions of a hospital, and at the same time we are also doing research on various aspects on bioinformatics with a lot of attention and a lot of focus on AI in imaging. So especially when it comes to data is something that's really important for us to do our work, but it's not always easy to have access to it. So although we have access to the software and access to the data, because the data is stored in our own software, we cannot really use it. We cannot really see it because it's part of they belong to the Ministry of Health when we're talking about public hospitals. So I'm also going to the presentation. I'm going to follow the template that has been given me by Montse. I'm also going to integrate some key messages coming from the HDS AI Connect 2026, the Cyprus presidency event that took place in Lemesos the previous week. And I'm also going to say that I wasn't looking at the presentations from the morning and from today. I don't think I am too original, because I keep seeing on the same messages coming up again and again. So what I saw I'm seeing as a key, and it also came up as a key challenge in Cyprus, is that there is an uneven national readiness and resource gaps. And this is critical because Europe is in a very decisive implementation phase. And if we fail to bridge national readiness gaps, this will prevent the member states from meeting the 2027, 2029 deadlines coming from the HDS regulation. This is that has been mentioned earlier. I think 2029 is too close. It's not that far. It's too close, I think. And the fear is that HDS will remain a paper regulation, and there is a fear that Europe will lose further ground in the global race for AI-driven health innovation. My focus will be mainly on, I'll have a focus on AI, not in general on health data, because also I believe that AI is going to play a very crucial role in the processing of health data, not just for training new models, etc., but in how we also read them and using them for making statistical analysis and reports, etc. So the urgent implementation problem is the uneven national readiness and the resource gaps. We have seen, we can also see it, we have seen it also in Preciseu in the report that Monse mentioned earlier, that particularly regarding the governance of the secondary health data, there is an uneven level of maturity. While the EHDS regulation entered into force in 2025, it is revealed that only a few countries, among them Spain, has formally notified the European Commission of their designated health data access bodies. And not only that, but there is a critical resource gap. Only 40% of countries have even discussed budget allocations for these new bodies. And I think only a small group, Belgium, Germany, and Spain, have approved multi-annual funding plans. So there is an asymmetry in both in digital infrastructure and political commitment to have a unified data space. So we have the regulation at EU level, but when it comes to member states, the paths in front of us are not very clear. And coming from a country, from Greece, I'm going to discuss Greece a bit further. All this is very critical. Because we see other countries making huge steps, huge leaps forward, and we are not as quick in implementing as we would like. And everybody's affected. All the stakeholders are affected from that, because the patients and the citizens in less prepared member states will be unable to exercise our rights effectively. And the opt-out mechanism of accessing our own data through the EU digital identity wallet, that's going to be in different levels. We won't be able to do it equally. And we will also have places in countries or regions where the implementation is not going to be as quickly done. We are going to have a lower quality of care, and medical actors will not be able to follow us across borders. For researchers and AI innovators, we are currently trapped in a tedious journey where applying for data access can take months or years. In our case, in Greece, it's an impossible game. For example, we have a barrier at the Ministry of Health, which is an infinite barrier. I mean, we cannot really cross it. So it's very difficult to get a permit to get access to data. Without a harmonized HDAB working, we cannot access large-scale, diverse European datasets necessary to train and validate trustworthy AI that performs reliably across different populations. For healthcare professionals, because they will face an increase in implementation burden and potential burnout if new digital systems are not user-friendly or integrated seamlessly into clinical workflows. This is really important, and this came especially for primary use. I know we are mainly discussing about secondary use, but this is really important with health data. The doctors need every digital tool to be integrated seamlessly in their workflow in order to use it and in order to get any value of it. And of course, for national health systems, because countries lacking in implementation will suffer from reduced system resilience and a continued reliance on fragmented and paper-based workflows. And they will not have the data in order to plan, in order to become more efficient. Well, if nothing changes, well, first of all, it's quite evident when we are saying it quite often that we are going to lose. Europe is going to have a loss in global competitiveness. we are going to continue losing ground compared to US and China, especially when it comes to artificial intelligence. Personally, I'm for less regulation than more regulation. And I understand there is a balance that we need to strike and find, but the actual danger of becoming irrelevant compared to the strides that China and the United States are doing it's really in front of our eyes. The HDS will may become a regulation on paper without the necessary human capital and technical infrastructure. The framework will remain a theoretical exercise than a transformative learning cycle. There might be a systemic trust breakdown if the public does not see tangible benefits like better diagnosis or personalized treatments early in the process. The social legitimacy of data sharing will collapse, leading to widespread resistance and further data siloing. And the last but certainly not least, widening inequalities. Instead of a unified European health data union, a digital divide will grow between member states, where the quality of a citizen's healthcare and the success of their country's research depend entirely on their geographic location. And that's not, then we are going to lose completely the whole point of AHDS. Now, the policy architecture, I think there is the EHDS regulation. I think many things have been discussed. It has been discussed in detail before, and especially by Laura before me, and I'm not going to even dare say a few more words about that. But I need to stress the importance of the EU AI Act, which is the primary regulatory framework ensuring that artificial intelligence deployed in healthcare is safe, transparent, and accountable. And it needs to be also trustworthy. The EU AI Act regulates the high-risk AI used in healthcare. It requires clinical validation, human oversight, transparency, and accountability, and emphasizes the AI generalization ability, increasing the need for diverse EHDS datasets. We need to ensure that the system performs equally well in different national environments. This necessitates the diverse datasets provided by HDS. And also the AI Act introduces specific obligations for AI deployers, including individual physicians and hospitals, requiring clinical validation, human oversight, and accountability for high-risk AI tools used in diagnosis or treatment. It should be noted here that especially when it comes to secondary use, this act is going to be very critical in how researchers can use data to produce new knowledge, or even for small and medium enterprises, small SMEs that wanted to train their models and to create new innovative services or products. And just to put to open a parenthesis here, usually large organizations, large companies, large pharmaceuticals, they have all the legal teams behind them in order to support them in how to navigate the legislative and the regulatory landscape. For a very small, for a research center or a university or a small company, the landscape is not really a landscape, it's an ocean, which is dangerous and with large waves, and they don't have the financial capacity to really follow everything and really do what needs to be done. So the EU AI Act the EHDS regulation is a regulation that it's actually helpful in a way, and it's something that really assists whoever wants to do research to do to know what needs to be done. The AI Act, on the other side, is going to be a little bit more of a challenge that needs to be solved. So we need to see how we can provide the assistance to actually help those who want to do the research on and use AI to navigate them through the problems. And then we have the EU funding programs. If we have EU for Health and Digital Europe at European level, which help fund necessary activities. For example, from EU Health for Health, I think we have the funding from XTEHR with primary use specifications, at EDAS2 for the secondary use guidelines, and from Digital Europe we have funding coming from actually strengthening and developing technical infrastructures, but not only that, we also have, let's say, for funding infrastructures like Cancer Image Europe. And also we should mention the digital innovation hubs, which are also trying to provide assistance to SMEs and the public sector in digital transformation, and also tackle issues that deal with health data and specifically AI. I think that the second iteration of funding from Digital Europe for digital innovation, for European digital innovation hubs, had a very specific targeting on AI. Now, where the system stalls, I think here also we are very not something new. We have the regulation, well, the labyrinth of complexity. We have legal uncertainty and the labyrinth of regulation that creates high barrier to entry for innovators and researchers. The developers need to navigate the complex interplay between EHDS, the AI Act, GDPR, and sectoral rules like the medical device regulation. Additionally, it was mentioned earlier, the inconsistent national interpretations of GDPR and potential gold plating of additional national requirements cause fragmentation. There is the financing gap, the sustainability gap, critical resources gap, and lack of multi-annual funding plans across most member states. As I mentioned earlier, only 40% of countries have even discussed budget allocations for the health data access bodies, and very few have approved multi-annual plans. And there is a lack of startup funding to move projects from successful pilots into routine production, combined with high computational costs for on-premise AI infrastructure. This is also discussion for primary use, how we are going to implement AI infrastructures in hospitals, which have a high cost of sustaining and actually being operating. We also have the procurement and ecosystem and the competitive pressure. We have in Europe, we have a very slow pace compared to the US and China in scaling innovation. This has been observed. This is for decades now, not just, it's not a current issue. And the other issue, something that we see as a result, is that European startups often exit the continent in search of faster access to capital and data. There is also a lack of clarity in buy versus build decisions within hospitals, leading to a scattered and non-interoperable AI solutions. We mentioned that the asymmetric readiness in data governance. There is a significant asymmetry in national maturity regarding digital health governance. And the root cause is that the implementation is highly uneven. We know, for example, that many member states lack the basic digital infrastructure to support a unified data space. There is a level of infrastructure and the legacy and technical debt. We have a continued reliance on fragmented and paper-based workflows and a lack of technical capacity. Many legacy systems across Europe. We do not know how we are going to. It's not easy to integrate them with the mandatory health to have the interoperability with health.eu. And the scalable pipelines for data linkages and secure processing environments are computationally demanding and technically complex to build from scratch. Trust, low levels of citizen awareness and clinician burnout regarding new digital tools. What we have said earlier, the frontline, the clinicians, and they need to have all these tools integrated in the workflow so they work together. And we also, it was mentioned by Laura earlier, the public trust is fragile, and in some leading countries like Finland, it is estimated that less than 1% of citizens are aware of their new data rights or the opt-out mechanisms. Although FinData, as Laura mentioned earlier, was very, let's say, not innovative, but one of the first examples of a structure that's working as a health data access body. And for clinicians, there is also the fear of death by 1,000 clicks, the pure usability and a clear liability for AI-driven decisions that creates resistance to adoption. Finally, we have the misalignment of success concerning metrics. Success is very frequently measured by regulatory milestones rather than tangible clinical outcomes. And I think that we are here, the discussion is, we are doing is very evident on that. There is a lack of established evaluation criteria to determine which pilot projects are robust enough for EU-wide out rollout. And the policy makers and EU and national level as well often celebrate too early at the point of legislative adoption, while the actual use of cross-border services remains limited. And now an example with evidence. My instructions were to give a good example, but I'm familiar with the Greece example, which is good in some things, bad in some others. And I think there were many examples given earlier. So what we did in Greece since 2020, and especially because of COVID, we had to implement the digital transformation of our health system very rapidly. So very quickly we had to expand our e-prescription and digital services, and we did adopt in 2023 a law on digital health transformation. We also had luckily a lot of funds from EU Recovery and Resilience Facility, which helped us in building all the necessary infrastructure to implement most of the necessary activities. So at the moment, we participate in My Health at EU and EHDS preparatory activities. The central coordination is done by the Ministry of Health and IDICA. IDICA is a society anonyme, but it's wholly owned by the state, and IDICA is responsible for all the e-prescription and all the electronic health data records, and managing also the H cloud, where all the data are going to be centrally saved. So the electronic health data records are stored centrally. At the moment, we are having laboratory tests and we are building the infrastructure for imaging records. We are also gradually developing interoperability and secondary use governance structures, but we are not there yet. So the results that we have, e-prescription has been achieved. We have near universal population coverage. Paper-based workflows have been reduced, have been unified, I would say. The systems are working well. There was a bit of resistance in the beginning, but especially from the doctors, because the initial versions of the systems were not very fast. But now I think we are doing very well. The citizens, we have a mobile application where we can see everything in our electronic health record. We have complete access, and also there is an obligation from all the organizations that are being reimbursed to pass all their findings, all their test results, etc., in the AIDS Cloud, in the electronic health record of each citizen. However, when it comes to secondary use of health data, the situation has not been has not been improved. Still, there is not a fully operational health data access body, no infrastructure yet to gather significant data. We only have laboratory tests from blood tests, etc. The data is still fragmented, and it's still impossible to get a permission for secondary use, because you have to ask the Ministry of Health, and the Ministry of Health currently uses GDPR for giving permission. When it comes a comparative lesson or cautionary example, I took the liberty of using our deliverable from Preciseo to make some, let's say, a table of what's transferable and not directly transferable from our findings in readiness framework. We see that EHDS readiness is uneven but not absent. We see that the most transferable elements are governance templates, not whole systems. HDAB style access bodies, one-stop shop access portals, national catalogs, secure processing environments, data literacy programs, and the regional national coordination mechanisms can be transferred, while what is not transferable is the institutional starting point, because there are different depending on country. We should, EHD's implementation should not copy best performance wholesale. I think, Laura, that was also your message concerning fin data, which is a very, let's say, best case scenario, or a very good example. But it should transfer modular mechanics and adapt them to each country's governance model, regional structure, digital maturity, and workforce capacity. Now, if somebody wants to check the priority actions for the next 24 months, I see that we should prioritize AI literacy and digital skills, both at actionable at personal level, professionals to train them in AI, interoperability, data governance, and to use AI safely as a support tool, but also at policy level. It's very important, and it was also raised during Cyprus. We need to update medical curricula and mandate workforce upskilling in digital health and AI. This is very important for primary use, but if we have a good understanding and entry at primary level, these data will also be very significant for secondary use. We also need to see that we need to validate AI before clinical deployment. So for professionals, we need to ensure that they will conduct a local silent mode validation to test AI reliability on local patient populations. And at policy level, we need to fund sustainable implementation, reimbursement models, and hospital infrastructure. And the third one is going to strengthen EHD's governance and trust. The professionals need to contribute to TEDAS and other EHD's consultation to improve usability and feasibility, and at policy level to establish, of course, the HDAVs, citizen information points, and transparent opt-out mechanisms. We could see some relevant indicators we could use to measure this, to support these actions. It could be the number of healthcare professionals completing certified AI digital health training, percent of hospital AI systems undergoing local silent mode validation before clinical use, and the last one is then, of course, is more general one, a number of fully operational health data access bodies connected to Health Data EU. I don't think at the moment we have a record on the baselines, but I think we could. It's something that maybe a policy maker or at a policy level, it should be given some effort, some priority, because I think that these are really steps that can be really implemented quickly, and they are not too large scale intervention to be done that needs a lot of time to be done. Now, regarding the workshop handoff and the challenge, maybe something to be discussed on your on-site event is how to move from parallel primary and secondary use implementation blocks to a single continuous EHDS learning cycle. And the goal of the challenge would be to ensure that there are no longer viewed as separate technical or administrative work streams, but as a connected system where the citizen is the ultimate beneficiary. And participants should work on a design that integrates 4 distinct stages into one loop: how to capture high quality interoperable care data at the bedside, how to govern the secure secondary use of that data, how to validate evidence through research and AI development, and how to translate those insights back into health system improvements and better patient outcomes. This is it more or less. Thank you.